Hello, and welcome to the Dr. Money Matters podcast, the show where we discuss important financial topics that were never covered in med school. I'm your host, Dr. Tarang Patel. Okay, welcome back to another episode of the Dr. Money Matters podcast. I have an interesting episode today about a couple of young physicians starting direct primary care practices, and another physician, Dr. Clodagh Ryan, who's been doing this for a little bit, who has mentored physicians in the practice. So I'm interested in direct primary care as a model because from what I've seen and one of my interviews in the past with Dr. Josh Umbehr, it seems like a great model in terms of patient care, in terms of physician satisfaction, addressing burnout issues, and giving physicians back control of the medical practice. So I know that I had several physicians reach out to me and get Dr. Umbehr's information back when I did that podcast. And I see on the various physician groups on social media, this discussion keeps coming back up. And so I thought it would be a good episode to get people together and discuss this issue, but from a little bit different perspective. So I wanted to thank my guests today, Dr. Mitch Li, Dr. Jessica Edwards, Dr. Clodagh Ryan, for coming on today. Welcome, everyone.
Thank you. Glad to be here.
Yeah, thank you. Happy to be here.
All right. So let's just go around a little bit and introduce yourselves. We'll start with Dr. Jessica Edwards. Tell us what got you interested in the direct primary care model.
All right. Well, thank you so much for having me. So I'm Dr. Jessica Edwards. I'm a board-certified family medicine physician. I also did an OB fellowship at the University of Rochester in New York. And I sort of got into the direct primary care model because I was really tired of seeing so many patients in a day and trying to keep up with so many of them. And coupled with the obstetrics portion of it, it was just really overwhelming. And I found myself not really being able to take time for myself. And I felt like such a hypocrite because I'm telling patients, hey, make sure you get enough sleep, make sure you exercise. And I was doing none of those things. And so my practice is a little bit different than just full direct primary care because I do provide obstetrics and I take care of the Medicaid population here in New Braunfels, which is right in between Austin and San Antonio. And my other family medicine colleagues that do obstetrics also take care of the Medicaid population. And so that's sort of why I'm hybrid at this moment. But I just want it better for myself. And so my first week of practice, actually my first day was May 21st. And it was such a nice day. I know, it was crazy. It was such a nice day because I was able to run on time. I spent an hour with a Medicare patient, just, getting to know her, going through her medical history, introducing myself to her specialist. And I've just been really happy over the last 2 weeks. It's a little bit of daunting, when you're starting your own practice or business, but the work is very, very rewarding. And so I kind of thought to myself the other day, I was like, I should have done this months ago, but I'm happy to be doing that now.
Okay, good. Welcome. Mitch, please tell me about your practice.
Sure. Jessica, that's really exciting that you just started. Congratulations on that. So I'm actually coming from a little bit of a non-traditional path, but I suppose kind of all of us are in the DPC realm. I came from a public health and sort of primary care background back in undergrad, really was interested in healthcare systems and kind of saw the shortcomings of our healthcare system for quite a while. But going to medical school, you kind of bury yourself in step exams. And I had another interest in emergency medicine back from doing wilderness medicine, EMS. And I was kind of choosing between primary care and emergency medicine. I went to University of Massachusetts Medical School, which is generally one of the top primary care schools in the country. But I was a bit torn, and I saw what primary care physicians were, with the system they were practicing in, and felt that it really wasn't going to be viable to practice the way I wanted to. So I went with emergency medicine, which I still love. And I actually transitioned from a W-2 job. I graduated residency 2 years ago, and I transitioned from a W-2 employed job just a couple of years ago, or just about 6 months ago now. And my goal at that point was to do independent contracting and really kind of work for myself. And this came after about a year and a half of just leaning into personal finance podcasts like yours, White Coat Investor, the blogs, Physician on Fire. And that's actually what gave me the sort of financial foundation to stand upon and the room to breathe and really look at this from a new perspective. And of course, I heard Dr. Josh Umbehr's podcast on your show. And it took me actually 2 listens along with another friend who said, that guy's onto something. And I listened to it a second time and kind of had a little bit of a eureka moment and said, wow, this is what's wrong with the healthcare system, or this is really the root of it from a physician and patient standpoint. So I called Josh Umbehr up. I just found him on his website. And of course, he is an extraordinary speaker and has so much passion, takes time for physicians. And that's only about 4, 5, 6 months ago. And I've been planning a practice since then, which is I'm still developing exactly how I'm going to roll it out. But I have my LLC and a website. I've started to get different vendors. And I'm thinking of opening a smaller, slow growth micro DPC this fall while continuing to do moonlighting and independent contracting as an emergency physician.
Very nice. Okay, good. And Clodagh, how about your practice? You've been doing this for a little bit longer. Tell me about your practice.
Yeah, that's right. I do feel that I definitely took a non-traditional way to come to this point in my life. I'm originally from Ireland, and I actually went into med school right from high school in Ireland, did a 6-year track, which is the norm there. Worked in Ireland for most of my 20s in different primary care facilities, and then ended up moving here and doing residency at the end of my 20s, and then joining a private practice in this area for about 8 years, while having 4 children and raising them as infants, etc. So I just, like Jessica, I really was starting to get frustrated with, I love the patient interactions, but the rest of the job was just so demoralizing and frustrating that for a few years, I was thinking, really soul searching and thinking, well, am I going to continue doing medicine at all? What else can I do? So I went through a lot of different scenarios, but I kept coming back to the fact that I loved talking to patients. I loved that interaction with patients. And so I discovered direct primary care through another, actually a residency faculty member who started a DPC practice in the south suburbs of Chicago, and reached out to her, had breakfast. Just like Mitch, I had that light bulb moment. That was in January 2017. And I was lucky enough in my private practice that I did not have a non-compete. So I was able to, within the next 9 months, prepare and solicit my patients from my previous practice, and started in September 2017. So I feel like I had a lot of luck, but I also did a lot of work before I started the practice. So there's so much help with the DPC community. First of all, I reached out to mentors who I thought that would be a good fit for what I was trying to achieve with my practice. One was, with Josh Umbehr. I think mentors a lot in the DPC up and coming community. He'll always give anybody time to answer questions. But I reached out to a couple of women too, who were transitioning practices. So Dr. Bhargava from New Lenox, Illinois was my original mentor. Dr. Kissy Blackwell is in Texas, actually. She's in Wichita Falls, was transitioning a few months before me. She was a big influence. Dr. Korba in Pennsylvania. I think that was a big help for me because there's so many different types of DPC practices, which is what we're hearing in this podcast, that, I think you'll always find a mentor that kind of fits what you're trying to achieve. So I started September 2017, and the day before I started, I had 72 patients enrolled. And by midnight that night, because I had waived the enrollment fee, I had 98 patients enrolled. I went to sleep, and after I went to sleep, the 20 patients enrolled in that last hour, they wanted to get this discount. So I started with just under 100 patients, and the first year was pretty fast growth, and now it's really slowed down very nicely. So where I'm at the point where I'm going to stick to around the 300 patient mark for now while my kids are smaller, and I'm almost there, and it's really a very nice fit, which I'm sure we can talk about later. It's been wonderful. It's not without its challenges, for sure. It was a lot of hard work, especially that first year. But now, in the last 3 months especially, I'm starting to reap the rewards of a very flexible schedule and time off when I need it, and convenience to my life versus the other way around.
So let's talk about that. That sounds awesome. I mean, a tremendous growth in just under 2 years' time. And it's funny that in that time span, you are considered a veteran now in the DPC community. But that's tremendous that you were able to get such good growth right off the bat. So, Dr. Edwards and Dr. Li are both kind of starting out in this in their practices, and so what challenges are you guys facing as you're starting out building your practice? I mean, I think it's probably true no matter whether you're starting a DPC practice or whether you're starting a traditional practice. What are some of the issues that you're seeing that maybe Dr. Ryan can kind of give you some advice on?
Sure. Well, so this is Mitch Li. I have gotten plenty of advice from Clodagh Ryan, and like I said, I started out with talking to Josh Umbehr, and he is still extraordinarily helpful. But I started researching practices in the area. So I'm in Chicago. Dr. Ryan is in the Chicago suburbs, so not that far away. There's very few DPC practices in Chicago proper at this point, and I reached out to Clodagh, and she is busy with many children. As a good
four.
Catholic Irish.
It's four.
From my zero, that's many children. But she's been incredibly helpful in taking the time between her practice and her family to sort of mentor me. And that's been really reinvigorating. I think I've kind of gotten ahead of myself in some ways and gotten excited about direct care as a whole and looking at the free market medical society and free market sort of medicine as a concept. And that's been something I've been really excited to work with Clodagh about, and more locally as well. We're working with some hospitals locally on that. As far as the DPC goes, my challenge is, and I think this is going to be a fairly ubiquitous challenge for a lot of DPC practices, is the personal finance and risk component of this. So, I mean, I'm in the generation that started out with a few $100,000 in medical debt. And like I said, if I hadn't really found the personal finance fire movement within medicine and in the community at large, I don't think I would have had the breathing room to start this at all. But still, I'm in the feeling that I don't really want to take on large amounts of debt or, private equity or venture capitalism funding or anything and start this big company and have all these pressures. So my challenge has really been kind of balancing the time where I have to devote to the business and paying down loans and reaching my personal financial goals. I think that's my main challenge. I know there's going to be many more within it, and I think another large one is just sort of explaining the concept to patients in general, as in terms of like marketing. I don't have a panel of patients that I had from a previous practice, so I'm building it from the ground up, which is a little bit another part of the challenge. But all of these things are very much overcomeable, particularly when you build some breathing room into your life with lowering overhead and being a bit more frugal.
So Dr. Edwards, your background is family medicine with OB, and you like basically are within a week or two of having just started your practice. What I'm a little bit unclear. Is your practice a solo DPC practice, or did you partner up with someone?
I am solo, 100%. Sort of the so I guess here's the caveat. So I'll preface this with my husband has his master's in business administration from Rutgers, so he's been my business mind. So I've really been fortunate to have him as far as being able to kind of give me some marketing advice, things like that. Because I guess part of the issue is that even with family medicine and OB is you give so much of yourself. I mean, whether you're just in clinic all day, whether you're doing deliveries at night. So a couple reasons why I transitioned to that was one, I wanted more call coverage. I was one and two, basically on call every other weekend for the last year. So now I've sort of branched, into partnering with some of the other community doctors, which I didn't know about when I first started. And so now I'm on call once every fourth weekend to do OB, and I have people, sort of supporting me in that sense. And when I started looking, I said, my husband and I sat down and we said, well, how do we find a location? We started looking at some locations. I find that, it really wasn't an issue for me, but that's something that I hear from most people who are looking into starting their own practice is finding that commercial space that's already, American for Disabilities, certified and, having space and things like that. And so I decided, I already had maybe about 800 patients at my other practice. And so I started telling my patients, I said, hey, I'm starting my own practice. And, just sort of explained to them what I wanted to do. And my neighbor actually owned a My Salon Suites building. And so I was sitting there talking to her one day and she said, why don't you come check my space out? And so she gave me the largest suite in the building. And it's like a mini doctor's office. And, she allows me to pay my rent weekly, like she allows anyone else to do. And I've gotten so many patients who don't have insurance. And a lot of the hairstylists in the building come to me also. And it's just been a really great experience. I would say part of my hardest things that I've been dealing with just sort of in this first couple of weeks, excuse me, is one, setting boundaries for myself. So, it's kind of saying, all right, 5 o'clock, my office is closed, I'm not, accepting any other, patients or, routine phone calls at this time. I have an answering service to do that. But, I try to run like right on time. And so I think, it's a good problem to have. All of my patients have been early. And so they'll show up like 10 minutes early and I'm like, hey, I'm still, with another patient. I'll see you back, at your appointment time. And I probably say some of the paperwork, it's not terrible paperwork. It's just like, record request forms and, some of the lab orders while I wait for my CLIA waiver and things like that. But overall, I would say I'm not as stressed as I thought I was going to be simply because my overhead is very low. I also do some aesthetic services to kind of counterbalance, as I wait to recruit more patients. So that's been very helpful as well.
So Dr. Ryan, you'd said you'd started out with a pretty good panel from your prior practice, and Dr. Edwards, it sounds like kind of the same thing. You had at least some your patients were aware of it, and then now you've got a built-in a group of patients from the salon area. How long can you anticipate before being where you were at in your previous practice in terms of financially? Dr. Edwards, you've only been in a week into your practice. So what are your goals or timelines for expecting to kind of be back to where you were financially before?
I probably would say my goal is maybe like 1 to 2 years. Um, the way that things are getting busy, I'm getting new patients almost like on a daily basis. And I've sort of streamlined the process for my practice where patients can book a new patient appointment online. They don't even have to talk to someone. My availability is my availability. And so I think with the aesthetics coupled with, you know, still having, accepting some insurance and doing the obstetrics portion of it, along with some commercial OB patients. I probably would say 1 to 2 years to get to where I was with sort of that steady income flow. But I was really surprised at how much aesthetics I did. Even like on Friday, I think as of Thursday, I didn't have that many patients booked. And the next morning when I looked, I had like 3 or 4 patients booked for like Botox and filler. And so I think that as that work continues to travel, I think that from a financial standpoint, the aesthetics will probably take care of a decent amount of things. And then the money that I make from my practice will take care of the rest.
And Dr. Ryan, how long did it take for you, if you're there yet or not, to get where you wanted to be? And it sounds like when you were saying you were pretty close to capping your patient.
Yes, that's right. So I think just a point to the previous conversation about starting and keeping overhead low.
Sure.
What I did was I made some inquiries to local independent physicians to try to sublet. And so I found a lady who the location is like half a mile from my home and less than half a mile from the 2 schools my kids go to. And she was willing to sublet one of the rooms in her office. And it worked out that she was going to stay. She was mid-60s, internal medicine. She was planning to stay working for another 2 years. But then once I started working in the office and paying her rent, she decided to retire because she offered me to buy the office. So I ended up buying my office 10 months in, which financially set me back from my original goal of, getting there by 1 year or whatever. But I ended up, it's been a very good long-term decision for me. I ended up renovating it as well. And now, it's a very attractive office. And I'll be here to stay. And it's got some room for growth, etc. So as regards my goals, I was breaking even and then some from the start because I started with 100 patients with low overhead. Right. And then I think, I'm definitely this year, I will probably be making about as much, if not more than what I was making in my previous practice. So, and that's a good amount of income for me at this point in my life. So, I would say reasonably, you would anticipate two things. One, if you're transitioning a practice, you're much more likely to break even or make a good living quicker because patients know you, they want to come to see you, they're going to come sign up. All you need to do is persuade them about direct primary care. They know who you are. But if you're starting from scratch, you have to sell yourself as well as selling direct primary care. So that makes it doubly challenging. So it takes a little longer to grow. And I would say the same with any private practice, not just direct primary care practices. Because when I joined my previous partner, it definitely took a good 2 to 3 years before I was fully busy, before patients got to know me and the word of mouth, referrals started to happen. So I think that's pretty normal for any independent practices. With the direct primary care, we just have to do a little extra work to explain the model. And that involves, going out and meeting people and lots of social media posts, etc. So I did do a good bit of that, but I didn't have to do as much as somebody who's maybe starting right from scratch. There is another direct primary care about 2 miles from me. She started last June from scratch. Her name is Dr. Aliyah Gupta, and she has been using social media to create a lot of buzz for her practice and has been growing very fast, which is absolutely wonderful to see. She's been a great support for me, and I've been learning a lot about the use of social media. And so that's kind of one way you can do it. And other ways are join business associations, networking groups, go talk to, moms groups, just getting your face out there and showing people how nice you are can really help sell yourself as well as your DPC.
How challenging has it been in terms of, and this is for any one of you to answer, selling the DPC model to patients?
Oh yeah, no, I think that's a great question, and I've sort of explored that from a few different angles. Coming from this finance background, I found this through personal finance, and one of the ways I've been networking in the area is actually to approach my local Choose FI Chicago group. And these are basically, people coming from all different walks of life in terms of not just medicine, but they are critical thinkers, and understand that the healthcare system is broken, but aren't necessarily just politically driven. Certainly there is so much politics involved in healthcare systems. There's lots of emotions, there's a lot of ideologies. And this group seems to address it a little bit more objectively. And so forging a relationship with them is a part of where I started in explaining the model. And I think they are primed to analyze it with a bit more open minds. And so that's been one angle of this. The other angle is, as Clodagh mentioned, showing that you're a real person, that people can actually see you as a person. Because I think our payment system and our employment model has separated us from patients so drastically that they just see us as part of the system now, and not as clinicians, not as physicians that actually have their interests in mind. So I think that's sort of the challenges that we have.
In their mind, and I think that anyone who's not familiar with the direct primary care model is, the Choose FI groups using social media, kind of, I would imagine, skews to a slightly younger or healthier population. That would seem to be probably something that would help build your practice a little bit easier. Is that the kind of patients that you're seeing, Clodagh? Or
no, actually, no. The younger, healthier patients, in my practice, we're age 21 through 35. People don't go to the doctor unless they have some chronic conditions, right? So it's in fact, some of the ones that I have signed up with me have been short term. They needed something 3 to 6 months and then they cancel. And primarily a lot of them have been that demographic. I'm finding, I always find this I'm in the western suburbs of Chicago, where, people live in the city of Chicago after finishing college for 5-6 years. They get married there, they have their first baby, and then they have their second baby and they can't fit in their condo anymore. So they move to the suburbs. So I get I've seen this through this demographic, for the last 12 years since I've been working here. They come in after they've had a couple of babies and they're not delivering anymore, Jessica. They need me for their, the stuff that's happening when they're 40. So I see a lot of patients coming in at that age group who and bringing in their families, and a lot of them are, I would say, a lot of them are self-employed or have had to buy health insurance for some reason. Maybe their work just doesn't supply it, and they are the current climate of insurance costs for the self-employed and the people who are buying it's just been rising. The cost has been rising so rapidly, something like 20 to 30% per year over the last 5 years. And it's just becoming cost prohibitive for families to even have an insurance plan which they think covers them. So when you explain that they don't need that full coverage that they think they need, that we as you take the primary care part out of their insurance plan and we can provide that, and then all they need is, a wraparound catastrophic plan or a health sharing plan, the light bulb goes off and they're like, whoa, what's the catch? I did have one guy who came to my first town hall meeting, which I did before I started the practice. I did 2 meetings for my current patients and advertised them, and because they had no idea what I was doing. I had to describe direct primary care, tell them I wasn't, leaving them, that they could come with me and hear this was really cool and they should look it up. And so actually everybody who came to those 2 meetings almost invariably signed up because it just made sense. But one guy came and he had not been a previous patient. He was referred by a friend of mine, 7 kids, self-employed. And he said, Dr. Ryan, what's the catch? I'm like, I can't tell you there is a catch yet. And they're still with my patients 2 years later. They're a healthier family, but they have had 2 significant hospitalizations for one daughter, which I have been able to support them with daily phone calls, sometimes 3 or 4 times a day when she was very sick, and helping them navigate that scary situation for a 10-year-old who she was admitted with bacterial discitis, which is a very rare, spinal infection. So they are just sold, and he's one of my what they call, I think, the people who just tell everybody how wonderful it is. He is one of those guys for my practice. He's just so, So I have several families like that. And then I have, ironically, there are a lot of Irish people from Ireland in Chicago. In my previous practice, I had less than 1% of people from Ireland. But because a lot of Irish people from Ireland in Chicago are self-employed, builders, plumbers, nannies, they came over, in the last 10, 15 years. The word has spread with the Irish community. So I'm at like 15 to 20% of people from Ireland. So I feel like I've created this niche I didn't even know I was going to create for Irish people, which has been wonderful. It just, I feel like I can understand them well, their personality types. So those are the main. Yes, some of them are healthier, but there are also, I have many patients between 50 and 85 who join sometimes for the insurance and the financial gains that they get from being in the direct primary care. Others need the access and the time. And so they join because then they can get access to me, which they need. So some of them take a lot of time, but I'm taking better care of them, way better care of them than I used to.
Right. And by definition, you have more time. So, I think that's one of the biggest things that, and you guys have described this, is one of the things that drives people out of the traditional see a patient every 15-minute model. And so that's, I think that's one of the things that really attracts people to this model. Obviously, when you're thinking about going into this into this type of practice, you want it to be financially successful, but we all went into medicine to help people, and that's really what it's after. And if you can do that while having an improved quality of life yourself, feeling like you've really made a difference at the end of the day, I think it's a win-win for everyone. So I really appreciate that, you guys are, having success in this model, and we can only hope that it continues to grow. Let me ask you, Dr. Ryan, you mentioned some of the practices that you had reached out to. Dr. Li, do you see any other emergency medicine physicians kind of going this route?
Well, like you said, this is a little bit of a non-traditional path, and I've been networking with just a couple of emergency physicians in the United States. Michael Garrett is, I'll call him out on there. He is a family physician. He was trained in family medicine, but worked in emergency medicine for 15 years before he found DPC, and now has a successful and growing practice. He's pretty well known in the community there. That's one of the first people I networked in that realm. And then I've networked with another emergency physician who is jumping into this realm as well. And we're having daily conversations, practically kind of reimagining how emergency medicine fits into this. There are family physicians that work in emergency departments. And so the other way around seems like it makes sense. We have a very overlapping realm of knowledge, and I think complementary in some ways. Speaking with Dr. Clodagh Ryan, we've been discussing what gaps there are in the DPC, what clinical challenges there are for patients in the DPC realm in terms of what services are we having difficulty accessing in the community for patients. And I'm still imagining how this can fit in. I think DPC is on the steep part of the diffusion of innovation curve. There's the early adopters and the innovators. And you have the Josh Umbers that are just clearly the innovators, and the innovation is still occurring, but we're just starting to hit that steep part of the early adoption curve. And I think DPC provides the foundation for this whole concept that we don't necessarily need to use insurance for all aspects of care. And in fact, it inflates costs many of the times. We think of a complete blood count, a CBC, a CMP is, relatively inexpensive, at least in the realm of direct primary care. We can get that for $2 or $3 generally. And so why would we bill for insurance for those? But we've generally thought of higher expense items as something that would be, insurance would be needed for. And I think that's true for true emergent hospitalizations, ICU stays, complex surgeries. But what we've found is that even things like an MRI are cheaper sometimes with direct pay. So
Right.
there's a woman that I spoke with in doing some of this marketing and outreach who had a history of breast cancer and was told by her oncologist that she needs an annual breast MRI, which she was paying $800 out of pocket with insurance. That was her copay. And looking that up, we can get an MRI locally in the community for about $325. So even with insurance, her out-of-pocket costs were massively inflated with that. And so we're exploring that with items in emergency medicine that are not necessarily resuscitations, but risk stratification. Like, for example, a CT angiogram to rule out a pulmonary embolism, something that's an urgent matter, rule outs for troponins, for ACS, getting a stress test more quickly. And so what skills does emergency medicine bring to the table that can complement DPC that isn't necessarily cost prohibitive? And we're exploring that kind of actively. There's another physician who is a direct pediatrician in the area that Dr. Ryan and I both know. And she actually called me up yesterday and asked if I could assist her with a patient, a barely 12-hour-old newborn that had some testicular issues that the midwife had brought to the attention of. She wanted to rule out the possibility of torsion or some kind of mass. I thought that, this is a little bit of a new ground that we were covering. And she asked me to bring my portable ultrasound. I just got the Butterfly IQ. I thought the pretest probability for any issues of torsion was quite low. So I agreed to go help her out, and we were able to do a testicular ultrasound in the field at a home visit, actually, and collaborate. And we were able to consult a pediatric radiologist in addition to my bedside interpretation that showed good flow, to rule out any torsion, which would be unlikely in this child to begin with. It was a hydrocele and everything looked good, but we were able to coordinate with an open-minded radiologist, and I had emailed you as well about this. And ultimately, this was an uninsured family that was paying direct pay, but probably would not have been able to afford an emergency department visit. Probably would have been somewhere in the range of like $5,000 once you add in the radiology bill, an ultrasound,
Sure.
Emergency department visit. And so it was a very satisfying visit, and it kind of opened my mind to, hey, can we complement these DPC practices in addition to me taking some patients and diving into preventive care? Can emergency medicine, can different surgeons really complement these DPC practices to get the best care at lower prices for patients? So we're actively imagining that.
Yeah, I think, when I had spoken to Dr. Umbehr, obviously the lab tests, more traditional outpatient imaging, things like that. I think all those things are tremendous. But what you're talking about is a very interesting twist on this is, more emergent and, definitely a much more costly component to care obtained, traditionally in our emergency room. So that's a very interesting twist on it. And the more you and other physicians in the with backgrounds in emergency medicine, can bring to this, I think that's phenomenal. I've talked to Dr. Keith Smith from Surgery Center of Oklahoma, and they do fixed cost surgeries, hip replacements. They do urology surgeries, ENT, at their place in Oklahoma, which is, still, again, it's a fixed cost, significantly cheaper. And so a lot of employers are actually partnering with them, sending their patients to them to, reduce out-of-pocket costs for the employers. Or if you're just going as as a cash pay, it's significantly better than you would get at traditional hospitals. So I think it's phenomenal that the three of you are part of this. What seems to be a national trend now in developing alternative and hopefully and soon to be mainstream ways of physicians getting back control of practices. So I want to, thank the three of you. I think we could talk for hours about this, but let me ask you guys to kind of me being a radiologist, it's not generally in my realm of practice. So I want to ask you if there's any questions that you have, Dr. Li, Dr. Edwards for Dr. Ryan, or vice versa, Dr. Ryan, tips or questions that you might have of them to, kind of advise them further as they start their practices.
Jessica, you want to go
Sure.
first?
So as far as getting your patients to transition from, using their insurance to direct primary care, do you have any suggestions there? The practice that I was at was mostly insurance based, and I think we have a PHO here in town that has contracts with most of the major insurers. And so even once I left the practice I was at, I was technically still a part of it. So I just decided to take insurance for the patients who I already had. But any tips of how you were able to transition people from using their insurance to paying you would be greatly appreciated.
Sure. So as I understand it, you're currently hybrid. You're doing insurance-based and direct primary care. Okay, and so I think the number one tip, and I think you're probably both on this group, but the DPC Docs Facebook group has answered most questions that you can ask as a new DPC doc multiple times, and that is where I got probably 90% of my information that has helped me build and grow and market. There's always the questions have been answered in so many different ways. So I think what I've seen on that group is that it is very hard to persuade your patients with insurance to sign up for DPC if you have the option to use their insurance, because they're all so indoctrinated in we need to use our health insurance to get our health care. So that's one thing that I see there are many docs, and I'm happy to give you some names of docs who are doing hybrid with the view to transitioning to just pure direct primary care at some point, who would have the answer to that question. I think secondly, you have to always, there's a few buzzwords in direct primary care, but one thing people usually say is like good health insurance does not mean good health care. So even though they have great health insurance, they can't get in to see their doctor in the hospital practice for 6 weeks, but they can see the nurse practitioner in 3 days. They can't get the nurse to call them back. They have to leave a voicemail or go through a phone tree. I know anytime I talk with any practice and I go through the front desk, it takes about 5 minutes to get a person on the phone, if you ever do. So that direct access is a huge part of that. Even people who have great health insurance are kind of tired of. We're all busy people. We've got all these busy working patients who don't want to sit for 45 minutes waiting for their doctor. They don't want to come in if they've just got a minor issue that they can be taken care of by phone. So those are kind of those things where you're like, that's the stuff that even the health insurance based docs, they can't offer that. So it's the convenience, the access, the personal relationship has actually been hugely important for me. Because I did transition, I think about 20% of my patients came from my old practice, and I've got to know them so much better that I think they benefit a lot from that personal relationship. So, encourage them to understand that you can actually, know about their family and know about the graduation coming up, or know that their father is on hospice, or those kind of things. You take that time. Patients start to really, talk to their friends and say, you know what, this is like an old time doctor-patient relationship here, family doc, small town. So those are the things I think that, access. I think there's 3 A's, affordability, access, and I'm forgetting the other one. One of you guys might remember, but it's all on the DPC Docs Facebook group. Join that group if you're not in it. Nice. Or reach out. I reach out to the other thing is the DPC community is very, very friendly, and mentorship is offered for free. And so I am currently passing it on to Mitch and some of the others that around me that I was given that mentorship I was given 2 years ago when I called or texted people multiple times, and they never complained and said, stop calling me. They just took every single call and every single question. And I think every DPC doc wants you to succeed, because the more of us there are, the more it will become easier for all of us to grow.
Very nice. I had one question for the three of you that, from an outside perspective, how do you determine, and obviously it's going to be different for each of you, but how do you determine your costs, your patient, the fees that you're charging your patient?
I guess I can take that because I'm in the middle of sort of figuring that out. This, I think when you discussed with Josh Umbehr, he talked about this as an evolution of concierge medicine. And, I had heard of concierge medicine, of course, I think, more or less everyone had, but it was sort of viewed as a way of, let's just get out of medicine and serve rich people and maybe, Michael Jackson medicine. Let's just have somebody pay insane amounts of money and it's not available to the average person, and we'll do a propofol infusion at your home. And that just didn't seem, something that was attracted me. So listening to Josh Umbehr, because there is a social, movement behind this. I think there's criticisms of direct primary care to say that this is only available to the rich. And I think the exact opposite is true. I found, if you look at Josh Umbehr's pricing, he's at $50 a person, I believe, that's age graded. And that's incredibly affordable. That's a low cost cell phone bill. Right. I found Dr. Ryan's website, said, okay, this looks like it's really embracing that kind of a model. And that's how I ended up discussing with her. I do think that physicians overall are used to devaluing themselves in the current market, as employees, and we're told, all through training that we're not good enough, or, we have a little bit of a imposter syndrome, I think. And so I think we should value ourselves quite well. And I think actually a lot of DPC physicians do underprice themselves, but our goal is really to provide value to patients, and something that's affordable to blue collar workers is kind of my goal. If you look at what's, I think Clodagh talked about all of these Irish immigrants that are self-employed, and that's kind of what I'm aiming for as a market, not necessarily as Irish. I don't resonate with the accent well, but that group that otherwise is kind of left behind in society. If you are, not that Medicaid patients don't get extraordinarily good care. Again, health insurance does not equal good care. They may not go into debt when they come to the emergency department, which is, I end up taking care of a lot of that population because they don't have good access. Otherwise, they can come to the emergency department. That's about it. And then if you're on the extremely wealthy side, then you usually have good access, although still if you're operating in the insurance system, you are still getting those 15-minute appointments. But I think the part of society that's really been left behind here is that hardworking independent contractor or self-employed person who is blue collar and making just enough money not to qualify for any subsidies with the ACA or with Medicaid, and not enough to really afford any good healthcare on their own. And I think that's the market personally that I'm aiming for. In this direct care marketplace, you can kind of aim at whatever segment of the population you want. And I know some that have prices closer to the concierge range, and I think that's fine if they, that's the whole marketplace. So in Chicago, we have some of the highest med mal environment in the country. So medical malpractice insurance is a bit more expensive. Taxes are higher. I'm aiming in that $85 realm. I think if you start too low, then people just devalue you. Just like an expensive glass, bottle of wine that's marked up is sometimes looked at as a better bottle of wine. Even in a randomized controlled trial, people think it tastes better than the exact same bottle that's priced too low. So it is a challenge. How can I be affordable to somebody who needs it, and yet be marketable to people and not look like we're devaluing ourselves?
Right, and I think this is these are some of the issues that that people who are going to be starting out are facing. But it's an evolving thing, right? So you can start out. It's your business now. You can make some mistakes, but you're absolutely right, Mitch. One of the things that physicians do is we undervalue ourselves quite a bit. So I'm glad to hear you bring that up. Because there is value in what you do, and like Clodagh was saying, I mean, the time that you spend with a patient. I mean, my goodness, you don't get that in any in traditional medical setting anymore. And so, once you do that with a patient once, I think you've basically sold them for life. If you can, get them to that point, because that's where physicians have lost their value, is that we are no longer seen as physicians, and we're just seen as commodities. 15-minute time span care, and then you don't see the same person, the next time you're there. So I think that's the thing that you guys are helping to fight. And I want to, like I said, we could go on forever, but I definitely want to kind of wrap it up here a little bit. So thank you all for coming on, and we'll look forward to seeing where you guys are at. Let me any closing comments that you want to say to any of our listeners?
Starting your own practice, whether you're hybrid for whatever reason, like me, just because I do OB and cover other physicians' patients, it's totally possible. It's doable. It's hard work, but it's very worth it. And if I had to do it all over again, even 2 weeks in, still being new, I would do it all over again, just to have more time with my family and to be able to truly appreciate my patients and fall in love with medicine again.
Wow, that's powerful right there. That's really good. Mitch, what about you?
Yeah, I'd have to say this has been really reinvigorating as far as medicine. I had a lot of sort of ideals, and a lot of us did going into medical school, and kind of became fairly disillusioned quickly. As I've heard from a couple mid-career physicians, they've considered themselves in a pot of slowly boiling water. The temperature starts out cool, and then over time they realize they've been in a pot of boiling water. In my generation of recently graduating, it's like we've jumped into a pot of boiling water, so we're ready to jump right back out. And so this has been really reinvigorating. As Clodagh mentioned, with the community is so supportive and has a mission, and that's I think going to pay off dividends in terms of career longevity. And I would mention one more thing to you, Trang, is that I think you mentioned a couple times you're a radiologist, and so it doesn't directly apply to you. And direct primary care doesn't. But again, I'm coming from this from a slightly different angle, and I'm realizing that direct care and all the support networks for direct primary care are vital. And so, as I mentioned, we collaborated with a pediatric radiologist last night who, some would be a little bit afraid of the liability. This is a kind of a curbside consult, as we discussed earlier. Is that going to be an issue with liability? And others are afraid, specialists are afraid of, violating any insurance contracts. There's a website, DPC Frontier, that deals a lot with the legalities of DPC. And I think something that Dr. Ryan and I have been working on is trying to reach out to specialists. And she has a lot of experience with this. Some are a little bit too afraid to do it. I would say to you and to other listeners that aren't in, family medicine or internal medicine backgrounds, that the DPC community really needs the support of specialists. And there are really innovative ways to do some sort of hybrid type models, like Dr. Edwards as well, where those specialists can support these DPC practices and uninsured patients with fair direct pay services. I think there are many innovative ways to do this.
Absolutely. I think you're 100% right about that. I think, specialists, like I said, most of us think we're kind of, we're not able to do it. And we're a little bit jealous in the sense that you can do it. So I think, the more we can educate about our, what roles we can play in it, particularly those who, may own their own, whether it's a surgical center, imaging center, things like that. I mean, I definitely think there's reach out to your local DPC community and see if you can get involved, because it sounds like it, and I'm sure you would correct me if I'm wrong, but you guys would be very happy to have us partner up in those settings and help arrange low cost, high quality ancillary services, imaging, whatever, to your patients. So I agree. I think, and again, the whole promise of DPC, lets you getting back to, taking care of your patients, whether it's from the specialty side, whether it's from the, the primary care side, but getting rid of a lot of the frustrations that we have in medicine. So definitely. Dr. Ryan, any parting words of wisdom?
I have a couple, yes. Number one, just to that point, Mitch is right. I've been doing a lot of work with the independent specialists in the area. So if anyone in Chicagoland is an independent specialist who wants to work with direct primary care practices, please contact me. I just set up a Facebook group to network for the independent practices so that we could provide services to each other on a cash pay basis. That's number one. Number two is don't be afraid of starting your own business. None of us have, I did not have any business experience whatsoever when I started, and I just dove in. I had a lot of help from my mentors. You have to have a little bit of energy and hope, and just don't be afraid of it, because there are many people running other businesses that are not as smart as we are, and they're doing a really good job. And then number three is that just the last point, we didn't really talk about this, but one of the other doctors get a little afraid of starting their own practice when they're going to be on call all the time. And I just wanted to say, it's a beautiful thing. My patients get so much time with me when they do come in during business hours that they don't call very often after hours. And when they do, it's a necessary call. And a lot of the time it can be taken care of by text. I sent a prescription this morning for eye drops while my daughter was playing in a piano competition, and I was faxing the prescription from my phone. It fits in with my life. I have 4 busy kids, and it is not too hard to do. I have never had a call after 11 p.m. at night in 18 months of being on call 24/7. So I just want to, because doctors in the system are so burned out that they don't want to entertain being available all the time, but it's a different feeling during the day in DPC. So you don't mind taking a call at 8 o'clock on a Monday, because it's really not that often. And that's it, really. Wow.
That's great. I think that, again, like you said before, that is, the old type medicine that a lot of us had in our minds when we were actually going to medical school. So that you're absolutely right. You won't mind that when it's a legit valued thing, as opposed to, and as a patient that you take care of routinely, everything about them, as opposed to handing it off to, covering call for some, one of your 15 partners. You know nothing about these people. So yeah, thank you. I really, it's inspiring to listen to you guys, not just from the patient care side of it, but from the, the business side of it. A lot of things that doctors are very afraid of doing now, and you guys are out there doing it. So thank you very much. Thank you for coming on this podcast. And I really am excited about sharing this with the community, because I think we need more encouraging stories in medicine with all the negativity out there. So I want to thank you guys.
Thank you, Tarang. Thank you.
Thanks for listening to another episode of the Dr. Money Matters podcast. I hope you guys were as inspired by this group of physicians who are taking charge of their future as I was. If you are a physician doing the same, whatever field you are with, but you're taking charge of your own practice or have gone independent recently and you'd like to be a guest on my show, just reach out to me via social media. Email me at tarang@drmoneymatters.com, all spelled out, or you can tweet me at drmoneymatters. I'd like to highlight as many physicians who are doing this and breaking out of this system as possible. Thank you. Thanks for joining us on another episode of Dr. Money Matters. If this is the first episode you have heard, I appreciate you taking the time out and listening, and encourage you to listen to our past episodes. I would also appreciate you leaving me a positive review on Apple Podcasts and also recommend you join our Facebook group where we have ongoing discussions about this and other topics in order to help each other reach our financial goals. Finally, I encourage you to subscribe to our email list and also to subscribe to the podcast itself on the various podcast app that you use in order to be kept aware when the latest episode comes out. More episodes of this podcast are available at www.drmoneymatters.com and on Apple Podcasts, Google Play, Stitcher, Spotify, or wherever you listen to your podcasts. Audio versions are also available on YouTube and Facebook. And you can follow me on Twitter at Dr. Money Matters or on Facebook or Instagram at Dr. Money Matters, all spelled out. Thanks for listening, and if you get a chance, please leave a positive review for this podcast as it helps move the podcast up the rankings on iTunes and gets it exposed to a wider audience. Thanks for listening once again, and stay tuned for another episode coming soon.